Welcome to the presentation on diabetic complications. The information from this presentation can be found in Chapter 49 in your book. We will start with the topic of diabetic ketoacidosis, or DKA. This is caused by a severe deficiency of insulin in the body, and it's characterized by hyperglycemia, ketosis, and acidosis. This is considered a medical emergency, and it's usually found in type 1 diabetes. The precipitating factors include illness, infection, inadequate dosing of insulin, poor management of diabetes, undiagnosed type 1 diabetes, and poor self-management, neglect, or noncompliance with their type 1 diabetes. This is a diagram from your book, and it shows the pathophysiology of diabetic ketoacidosis. Basically what happens is you have a decreased amount of circulating insulin, which causes fat stores to be broken down for fuel, and this causes a release of ketones. Ketones are acidic byproducts of fat breakdown, which causes acidosis. And when ketones become excessive in the blood, then they can start causing problems in the body. Signs and symptoms of DKA include a blood glucose of greater than 250 milligrams per deciliter. Also fruity breath odor from the acetone. Ketones, which are excreted in the urine. This is a hallmark sign of DKA, and this is called ketonuria. You will also see glucose excreted in the urine, and this is glucosuria. Kussmaul respirations is something that happens, and this is the body's way of compensating and trying to blow off the extra CO2. You will also see a pH value of less than 7.3. And there are many electrolytes that get depleted and excreted in the urine, and that's sodium, potassium, chloride, magnesium, and phosphates. The other signs and symptoms include dehydration and all the hallmark signs of dehydration, which include poor skin turgor, dry mucous membranes, tachycardia, orthostatic hypotension. You'll also see lethargy and somnolence and weakness, as well as anorexia and nausea, vomiting. And the vomiting can be from the acidosis. The hypovolemia can lead to hypovolemic shock and renal failure, and eventually a coma and death. The combination of the dehydration, electrolyte imbalance, and metabolic acidosis can cause the body to go into shock and can further to death if not treated in time. Treatment needs to be prompt, and usually is started with patent airway and oxygen therapy as your priorities, as well as fluid resuscitation via IV. And this is usually done with half normal saline or normal saline boluses. It's also important to replace those electrolytes that are lost. And insulin therapy, of course, will be started, and this is usually done in an IV infusion of 0.1 units per kilogram per hour. One thing to consider with treatment is once the blood sugar reaches a blood sugar of around 250 milligrams per deciliter, it's important to consider adding dextrose back into the IV fluid so that you don't end up with rebound hypoglycemia. The nursing management for DKA includes assessment of level of consciousness, reassessing the blood glucose levels, checking the electrolytes, the eyes and nose, assessing the vital signs, and looking for fluid volume replacement, ECG monitoring, and symptom management. Some important considerations when treating someone with DKA is that you want to rehydrate enough for them to meet their minimum requirements of urine output, which is 30 mils per hour. But you also have to be careful because too fast of hydration can potentially lead to fluid overload and also cerebral edema. You want to monitor for hypokalemia with insulin treatment because insulin actually drives potassium into the cells, so they're so the serum level of potassium goes down. So it's important to watch the ECG and check for hypokalemia and make sure that you're not seeing cardiac arrhythmias. Our next topic is hyperosmolar hyperglycemic non-ketotic coma, or HHNC for short. Your book refers to this as HHS. The name has just changed recently. This is also considered a medical emergency. It is less common than DKA, and it's found mostly with people that have type 2 diabetes. In this condition, the body produces enough insulin to avoid DKA, but not enough to prevent severe hyperglycemia. So precipitating factors include age, happens more commonly in patients that are older, above 60 years of age. Also in those with a new diagnosis of type 2 diabetes. Illness can trigger it, UTI, sepsis, an impaired thirst sensation, as well as acute illness such as pneumonia. The signs and symptoms of HHNC include a really extremely high blood sugar of greater than 600 milligrams per deciliter. The symptoms at first are kind of few and far, which allows the blood sugar to really get out of control before it is discovered that there's something going on. What you will find that's different about HHNC is that there are not ketones in the urine. So this is a huge difference between this condition and DKA. What happens in HHNC is the serum osmolality increases, which causes a lot of neurological manifestations. So you will see things like seizures, hemiparesis, aphasia, coma, a lot of things that are similar to a stroke. And also severe dehydration you will find as well. So you have an increased serum osmolality and related to the deficient fluid volume. The treatment is very similar to DKA in that you're going to do fluid and electrolyte replacement as well as insulin therapy. And it's important to consider the same things that we said before with DKA with the fluid and electrolyte replacement and the insulin therapy. Again, you'll have to worry about once you drop the blood sugar below 250 milligrams per deciliter, then adding in dextrose to the IV fluids to make sure that you don't get the patient too hypoglycemic. And of course, you'll want to use caution when replacing fluid volume because, especially with older patients, you have patients that might have some cardiac issues or renal issues that make it a little more challenging when you're replacing fluid volume. You have to consider that. The nursing management includes reassessing the blood sugars, the lab values again, checking your vital signs, level of consciousness, I's and O's, and again the ECG related to the insulin and the potassium. All very similar things to DKA. We're next going to talk about hypoglycemia, just for a little bit. Basically, it's when the blood glucose drops below 70 milligrams per deciliter, or you could say it's too much insulin in proportion to the glucose in the blood. The signs and symptoms of hypoglycemia include shakiness, nervousness, diaphoresis, hunger, pallor, as well as altered mental functioning, trouble speaking, confusion, stupor, coma, and potentially death if it's not treated. The brain requires glucose to function properly. There's nothing else that the brain can use for energy. Nursing management for hypoglycemia includes the rule of 15. And the rule of 15 means that you're giving 15 grams of carbs and rechecking in 15 minutes. And if the blood sugar is still below 70, you're going to give another 15 grams of carbs. And this will continue for about 2 or 3 doses. You may need to give a complex carbohydrate so that you don't end up dropping them back down. And you don't want to overtreat the patient. So those are all important considerations. You may need to contact the healthcare provider and figure out what is happening and why the hypoglycemia is occurring in the first place. Could it be that their insulin therapy is a little too much? Are they not eating enough? Are they NPO status? Those are all important things to consider. If a blood sugar is dangerously low or if the patient is unconscious, another way to treat that is to give the dextrose sub-Q, IM, or IV, and that will act very quickly in the body and bring their blood sugar back up. And then, of course, you would want to continue rechecking their blood sugar in 15 minutes and making sure that it continues to go up so that they are safe. Next, we're going to talk about chronic complications of diabetes. And there's macro and micro complications. So we're going to start with the macrovascular complications. In macrovascular, the damage that is done is to the medium to large blood vessels. And this can be seen with greater frequency and earlier onset with patients that have diabetes. So what happens is cerebrovascularly, they could end up with a stroke. In their heart, they end up with hypertension, heart disease, and in their peripheral vascular, they end up with poor circulation, PAD, and PVD. And there's also important contributing risk factors that make it much worse. Obesity, smoking, hypertension, high fat intake, and sedentary lifestyle all contribute to the damage. On the microvascular side, the damage is done to small blood vessels, the capillaries and the arterioles. So the first one that we'll talk about is the retinopathy that occurs with diabetes. And this occurs to the capillaries in the eye. And what happens is there is two different types. There's the non-proliferative and the proliferative. And the non-proliferative is more common, but the proliferative is more severe. And so basically you get these little aneurysms that occur with edema. And retinopathy is the most common cause of new cases of blindness in adults. What they usually do to treat this is they do laser photocoagulation, which destroys the ischemic areas of the retina. The next one that we'll talk about is nephropathy. So the damage to the small blood vessels that supply the glomeruli of the kidney is what causes nephropathy. This is the leading cause of end-stage kidney disease, and there's other risk factors with this as well: hypertension, genetics, smoking, chronic hyperglycemia. So basically it's important for diabetic patients to get screened for albumin in the urine and to also have their GFR checked to check how well the kidneys are filtering. Also really important for their hypertension to be treated because it actually accelerates the progression of nephropathy in these patients. Another one that we will talk about is neuropathy. And neuropathy is basically damage to the nerves, and they don't really know the exact mechanism behind it. But there's an accumulation of fructose and sorbitol in the nerves, and you have reduced nerve conduction as well as demyelination. And of the patients with diabetes, 60 to 70% have some degree of neuropathy. And there's two different kinds. There's sensory and autonomic. So sensory or peripheral neuropathy is also referred to as distal symmetric polyneuropathy. It's the most common form. It affects hands and feet bilaterally, and what you have is a loss of sensation or abnormal sensation, pain and paresthesia, so numbness and tingling. The pain can be described as burning, cramping, crushing, or tearing. You can also end up with neurotrophic ulceration. So these are the diabetic foot ulcers that you will see on patients. And so basically they have a loss of protective sensation, which leads to injury of the feet. The patient can't feel what's going on down there. So then an injury occurs and they have no idea, and it just spreads. For these patients, patient teaching is huge, and ways to prevent foot injury, of course. And that includes proper footwear, avoiding injuries of any kinds, skin and nail care, inspection of feet for anything that they might see that's sticking to them or looking red, and also prompt treatment of anything that does look like a small injury. There's a table in your book, 49-21, that also does some patient teaching for this sort of thing that you might want to take a look at. The other kind is the autonomic neuropathy, and the thing about this is that it can affect almost all body systems. So it can cause gastroparesis, which, delayed emptying of the bowel, anorexia, nausea, bowel incontinence, diarrhea, feeling of fullness. You can also have cardiovascular abnormalities, which include tachycardia at rest, postural hypotension, as well as a painless MI, which is an MI without any of the chest pain or anything that goes with it. Another one that can cause, that is considered autonomic, is the neurogenic bladder, which causes urinary retention related to a decreased sensation in the bladder. It can cause infrequency of voiding and difficulty voiding, and also a weak stream. And then finally, another area that can be affected is in sexual functioning. Men can actually end up with erectile dysfunction from this autonomic neuropathy. Another thing that you might see is dermopathy, and this is just, it's actually the most common type of skin lesion. Most frequently it's seen on the shins, and it can be red, brown in color and oval patches. And this is just something that is seen in diabetic patients. Diabetic patients are also prone to infection, and the reason behind this is because there is a decreased blood flow throughout the body, and the white blood cells are unable to mobilize to fight off that infection. And there's also a defect in the mobilization of inflammatory cells, and also have impaired phagocytosis, which causes infection to spread. Neuropathy may lead to delayed detection of infection, so that's another way. And patients with glucosuria can be predisposed to bladder infections just based on the glucose in their urine, and it can cause a buildup of bacteria and things growing. The biggest thing is that any kind of infection needs to be treated promptly as soon as possible. The nursing management, of course, with all of these is to maintain good glycemic control, good blood sugars, good A1C levels. And also it's important to treat the high blood pressure that kind of goes with the blood sugar. You want to encourage your patients to stop smoking, because that, of course, adds to the problems and makes damage to the blood vessels worse. Encouraging activity is important, and decreasing their fat intake and their cholesterol. It's a lot of patient teaching that you're doing to help with these conditions, even though it's hard to prevent a lot of these things from occurring. You want to do the best you can with your patients, and and help them with what is happening to their body and how they can best take care of it. And that is it for now. We will be doing more in class, and let me know if you have any questions. Thanks.